Okay, guys, and lastly, we are going to finish off with our spleen here. So the spleen is a pretty well-behaved organ for the most part. There's not too much craziness that happens with the spleen, and you can have it removed and it's totally fine. So it's kind of just like along for the ride in most patients. Doesn't mean it's not important, but it's just, again, a well-behaved organ. It's considered a lymphatic organ, so it's comprised of lymphoid tissue. It's actually the largest lymphatic organ that we have in our body, meaning it kind of keeps our overall immune system in check. It is considered an intraperitoneal organ, so it's located inside of the peritoneal cavity. It's covered by peritoneum in terms of protection. There is a small portion of the spleen that's not going to be covered by peritoneum, and that's going to be at the hilum where the vessels are entering and exiting. It's going to be positioned posterior in the left hypochondrium region, so it's very far back in our upper abdomen. It's going to be located between the fundus of the stomach and the diaphragm, so again, pretty high up there. The inferiomedial, so the lower inner surfaces of the spleen, are actually going to be touching the stomach, the left kidney, the tail of the pancreas, and the splenic flexure of the colon. Size of this is something that we do measure routinely. We're always measuring the length of the spleen. We don't want to see it greater than 12. If we see it 13, that's usually okay. But if we ever see a spleen that's measuring 15 to 20 centimeters, that's going to be indicative of some sort of splenic pathology. And it's usually only going to weigh about 150 to 200 grams. So this top picture here is a really great representation of where that spleen is going to be located in reference to everything else. You can see it's kind of sitting behind the stomach and the pancreas, and it sits really high up. So this can be hard for us to image because it's super, super high. We're going to be fighting the ribs. There's not really much that helps to push it down into our windows. So it's really important that we're having our patient cube towards us and taking these really deep breaths. Big deep breaths in to help us move that spleen down out from under the ribs if possible. So pretty straightforward organ, but can be a little hard for us to visualize in terms of patient to patient. Physiology of the spleen. So the main function of the spleen is going to be to help synthesize our blood proteins. It's going to filter those blood products, and it's going to help store some of those blood products if we were to ever need them. Say we had a cut or we got into an accident and we needed this reserve of blood to go to those specific areas. Our spleen would provide that. It also helps us to destroy the red blood cells that our body no longer needs. We know that production happens, the production and the destruction of our red blood cells happens really rapidly. So that's something that the organ is kind of doing overtime for. We also are relying on our spleens for our lymphoid purposes, so keeping our lymphatic system in check, helping with our immune system, and that's going to be helping to destroy microorganisms that are foreign to our body, keeping us healthy. It's going to also help contribute to fetal development. So the spleen, when a woman is pregnant, is crucial. It's going to help form blood for the baby itself, and then also we reference that as hematopoiesis, and then it's also going to help to form red blood cells in bone marrow. That's going to be erythropoiesis, and then the baby's spleen in and of itself is also going to be a really big resource in terms of that baby's fetal circulation. So the maternal spleen, while the mom is pregnant, is really working overdrive. We have about double the amount of blood volume in our body just to supply that baby, and so that the baby can form their own blood process and bone marrow process. And that's actually why moms tend to get very lightheaded, and they tend to have a hard time breathing, is because of that rapid production of red blood cells. It's also going to help us aid in the body's natural defenses, like we had mentioned earlier. So it's the production of lymphocytes, which is going to give us increased immunity, and the production of plasma cells, which results in our white blood cells and therefore producing antibodies when we are responding to an outside illness. Now, there are certain lab values that we have to be aware of in terms of the spleen. So there are going to be a lot of indications on an abdomen order that are going to signal to you to say, hey, I need to put extra emphasis and extra evaluation on this patient's spleen. So if we ever see leukocytosis or leukopenia, that's talking about the patient's abnormal white blood cell count. Leukopenia, they don't have enough. Leukocytosis, they have way too much, right? So they're fighting some kind of infection. Leukopenia, they have some sort of autoimmune or chronic condition that's not allowing their body to fight off what they need to fight off because they don't have enough white blood cells. Also, anything with a red blood cell count, whether it be increased or decreased, could again be related to congenital conditions that a lot of people can have from birth, a lot of genetic conditions that are hereditary. We're also looking at hematocrit levels, so kind of talking about the concentration of blood cells in a patient's blood volume. Is it too high? Is it too low? Platelet count. Anytime we see thrombocytosis or thrombocytopenia, again, how many platelets are in that patient's blood volume? Is it too high, meaning it's thrombocytosis? Is it too low, thrombocytopenia? So all indications that if we were to see on an abdominal exam that's ordered, we know that we need to put a little extra emphasis on looking at that patient's spleen. So vascularity in terms of supply and drainage, we kind of talked about this already. The supply is going to come from that splenic artery, which is going to be the branch of the celiac axis, which is a branch off the aorta. It's going to be tortuous. It's going to travel horizontally along the border of the pancreas, and it's going to enter into the spleen at the hilum. Once it enters into the splenic tissue, it's going to divide off into 6 smaller arteries, and those arteries are going to go and supply the splenic parenchyma. Remember, parenchyma stands for functional tissue of that organ. And then drainage, again, we did speak about this. So the splenic vein is going to be formed by smaller veins in that splenic tissue that are going to join together to form the splenic vein. And then that's going to exit the hilum, join with the SMV. Prior to it joining with the SMV, it's going to travel behind the pancreas, kind of through and behind the pancreas. And then it'll join with the SMV to form that portal splenic confluence, which will be the portal vein that supplies the liver. And again, nice representation of that kind of close up, just in relationship with the spleen, pancreas. So you can use that while you're studying all of these relationships. Some indications of why we would be doing a splenic exam. Sometimes we can do an abdomen limited where they want us to just look at the spleen and the left kidney, but usually we're doing a full abdomen with emphasis on the spleen. Anytime a patient has a palpable spleen, meaning it's really big and we can actually feel it through their chest and their flanks, anytime they have abnormal lab values like we talked about, left upper quadrant pain, any history of an infectious disease, or if they have any kind of sickle cell disease. So meaning the shape of their blood cells is abnormal. We want to be looking at the source and the origin of where those blood cells are coming from. So how should this look on ultrasound? It is challenging for us to evaluate the spleen because of those ribs like we had said. Even on a perfect patient, we're always going to kind of cut off a little bit of the border. And that's just the nature of this organ. It's located really high. It's located really close to the diaphragm. So we're always going to have a little section that's a little bit too close for comfort. And that's something that radiology and the radiology world has kind of come to grips with. Like we've kind of accepted that we're always gonna maybe cut off just a little bit. And I put emphasis on just a little bit, okay? I don't wanna see you cutting off the spleen here and being like, oh, I just can't get that border. No ma'am, right? So we wanna make sure that we are doing the best we possibly can with those borders that can be hard to find. The organ itself is going to be oval in shape or ovoid, homogeneous, all the same shade of gray, smooth. It's going to be a little isoechoic to slightly more hyperechoic than the liver. The superior border is going to be convex, and then the inferior border is going to be concave. So convex, concave. And then the shape and the size of the spleen is really going to vary depending on patient's medical history, patient's age. As we get older, everything kind of gets a little bit smaller, shrivels up, starts to die, which is just very morbid, but it's true. So again, if a patient's fighting some sort of autoimmune disease, that spleen's going to look different. If the patient's fighting some sort of infection, it's going to be big. That spleen's going to be big. So you definitely want to be aware of all of that when we're looking at measurements. Prep for the spleen in terms of an exam. Again, it's usually going to be part of a standard abdominal exam, so an MPO for at least 6 hours, 3 to 5 megahertz curve transducer, scanning the patient starting in a supine position, but we are usually always going to have to roll them on their side towards us, so a right lateral decube or a right oblique to elevate that left flank upward, and make sure you're evaluating all of the borders. Again, if we're cutting off a millimeter of that superior border, it is what it is. But I also know that you can probably get more than what you're going to think that you can get at first. So we're definitely going to work on this in lab as we go. Protocol, always looking at it in sagittal and transverse. We're getting a spleen and kidney interface in both views if possible. We're also doing a dedicated sagittal spleen image with a length measurement, and then we're putting color on at the hilum to evaluate those vessels entering and exiting. And we're following that similar concept with transverse. So again, that interface with the kidney, dedicated transverse spleen picture. Some places will require you to do a width and a height. We do that in transverse, and again, putting color on in that hilum to just get a second view of those vessels. So here we have what our picture should look like. Now, when we have the spleen in sagittal, it's going to, really when we have it in both views, it's going to look like a moon, right? But in sagittal, it's going to be like a C, a standard C shape, kind of, right? And then in transverse, it's going to be the exact 180 of that. So it's going to kind of be a backwards shape. That's the only difference between sag and transverse. And it's because this organ is very oval in shape. That's why it looks super similar when you're flipping that transducer. So sagittal, these top 3 pictures here, we're measuring kind of from tip to tip there, putting color on in both fields of view. And then in transverse, if we were to be measuring this, this would be our height and our width. Again, we do have normal variants for this organ. Accessory spleens are also known as splenules. These are very, very common, usually going to be about 1 to 3 centimeters, and we can see multiple of these. It's just kind of this little ectopic splenic tissue that we see usually on the inferior, more concave border of the spleen. Sometimes we can see them up here at the tip, but they're benign, they're harmless, they're kind of cute. They're like these perfectly round little balls of splenic tissue. We also can see aplasia, which means that the spleen never formed. They just congenitally don't have a spleen. We could see hypoplasia, which usually progresses worse over time. So it means it just gets smaller and smaller and smaller. Hypo meaning smaller or less than. Aplasia meaning completely missing. And then we also can have wandering spleen. That is something that is really bizarre. And it's usually just when a patient has a spleen, but it's not going to be located in that left upper quadrant. It could be located in the left pelvis or in the left flank. So just because we don't see a spleen where we're used to seeing it doesn't mean we stop looking for it. Yes, the patient could have aplasia that they don't know about, but they also could have wandering spleen, and it could just be located lower in the patient's abdomen than we're used to looking. So we don't want to give them a diagnosis of aplasia when it's just wandering spleen. So a lot of information on here. Again, I can't stress enough the importance of knowing the relationship, especially between the vascularity of all of these organ systems. We are going to be practicing these a lot in lab, so I'm not as concerned about you understanding the protocol or how we obtain the images or the measurements. I do want you to understand the relationships. So I think, the horse is very much dead at this point, but if you have any questions about any of this, please do not hesitate to reach out to me. And we're going to be taking these kind of one area at a time when we are starting these in lab.